Good day and welcome to our tutorial sessions. I hope we have been enjoying and learning from our tutorial sessions so far. So today we'll continue with our discussions on benign breast disease. So I'm sure we remember this classification which we talked about the last time, that benign breast conditions generally are divided into two. We have the benign breast neoplasms, and then we have the non-neoplastic conditions. So for the neoplastic conditions of the breast, that has the neoplastic benign breast conditions, we have fibroadenoma, cystosarcoma phalloides, duct papilloma, and lipoma, which we talked about in our previous discussion. And then we have the non-neoplastic conditions, which includes aberrational anomalies of normal development and involution of the breast, called ANDI, inflammatory breast disease, mammary hypertrophy, breast abscess, Tietz syndrome, traumatic fat necrosis, and galactosile, some of which we'll be talking about in our tutorial session today. So we'll begin with ANDI, aberrational anomalies of normal development and involution. So it is important to note that the breast is an organ that undergoes changes of development, cyclical proliferation, and then eventual involution during a woman's life cycle. So because of these changes that occur, it's not surprising that certain anomalies may occur during the process of development, the monthly hormonal changes, and then involution. So for disorders of development, we have fibroadenoma, which we have talked about before, and then we have disorders due to cyclical hormonal changes, benign mammary dysplasia, which is also referred to as cyclical. It's one of the features is breast pain, that's mastalgia, and cyclical in nature, that it is occurs monthly during the menstrual cycle. And then we have disorders of involution, including those that affect the lobule and then those that affect the ducts. Then for the lobule, we have cysts and sclerosing adenosis, and then we have duct ectasia. So first we'll talk about benign mammary dysplasia. Other names to describe this condition includes fibroadenosis, fibrocystic breast disease, and then chronic breast mastitis, amongst others. So it's common between ages of 20 and 45 years, which is the reproductive age group. It's uncommon in the postmenopausal period, so it's common in the reproductive age group, as I earlier said. The cause of this condition is uncertain, but it can be traced to hypersensitivity of the breast epithelium to normal circulating hormones, especially estrogen. This can explain the reason why it's common in the reproductive age group, because of the levels of estrogen. Microscopically, so when you look under the microscope, you see the following features. There's stromal proliferation. Remember that the stroma is made up of fats and connective tissue. So when there is proliferation of the connective tissue, it results in fibrosis. And then the ductal epithelium undergoes hyperplasia, and this is described as epitheliosis. There is also glandular hyperplasia, that is the acini of the breast, that is the glandular tissue, undergoes hyperplasia. This is described as adenosis. With stroma, that's following fibrosis and then epitheliosis, there is blockage of the ducts. Now the duct is supposed to drain the content of the acini. When the ducts are blocked, it results in dilatation of the acini, and then there is resultant cyst formation. We should remember that this condition is not pre-malignant, but the risk of carcinoma is increased 5 times in patients with atypical hyperplasia of the epithelium. Here's a diagram to describe the fibrocystic mass. Here are cystic masses, have cystic masses, and they are surrounded by fibrous connective tissue. Remember, we said the fibrous connective tissue undergoes proliferation, leading to fibrosis, and this occludes the ducts that ought to drain the distal that's the acini, and with abnormal dilatation of this acini, there is resultant cyst formation, as you can see in this diagram here. So clinical features: pain. Usually there is pain which could be cyclical or non-cyclical, and then you could have a lump, or it could be just a lump, or there could be lumps because of the cystic changes that occur. There may be lots and lots of cysts that may result in lumps. And then because the ducts are affected, always remember that whenever there is affectation of the ducts of the breast, there is usually nipple discharge. So there could be a serous or a greenish nipple discharge. And then on examination, when you feel the breast appears lumpy because of the numerous cysts that it contains. And then you may also feel small nodules which are firm, tender, with irregular edges. And then axillary lymph node is usually not enlarged because it's not an inflammatory condition, and it's not also a malignant condition. So the axillary lymph nodes will usually not be enlarged. So treatment, it's conservative, includes conservative management, medical management, and then we also have surgical management. So under conservative, patient is usually reassured. So patient is reassured and that she has got no breast cancer, and sometimes reassurance is all that is required. Now the breast may be supported with tight fitted braziers. So the breast may be supported by wearing tight fitted braziers, and then the parent should be advised to stop the intake of oral contraceptive pills just to reduce the level of estrogen in the body, and then also to reduce the intake, or rather stop the intake of xanthine containing substances such as coffee, tea, chocolate, and cola, because it has been found to be helpful in relieving the pain. And then the patient should be followed up for a while following conservative management. Now, medical management is usually initiated when conservative management fails, or when you've assessed the patient and the patient presents with features that require medical management. So it includes giving topical NSAIDs for the pain, and then have evening primrose oil. It is rich in polyunsaturated essential fatty acids, and it gives relief in most patients with both cyclical and non-cyclical pain, that's mastalgia. And usually patients should be followed up to ensure compliance, because the effect of the drug is usually seen after 2 to 6 months. So patients should be followed up and should ensure compliance with the drug. Patients should be told that effect may be seen after 2 to 6 months. Now, danazol is another medical agent used to manage benign mammary dysplasia. Danazol is an androgen. When it's given, it inhibits the release of luteinizing hormone and follicle stimulating hormone, therefore reducing the level of estrogen in the body. And this is said to relieve the pain in about 40% of patients, usually given for 6 months. But the side effects will include androgenic changes such as acne, deepening of the voice, increase in weight, amenorrhea. So that's the side effects of danazol. Then tamoxifen is another agent used. Tamoxifen is an anti-estrogen that is used in the prevention and treatment of breast cancer. So it has been shown to relieve the pain of benign mammary dysplasia, and usually it is started following failure of conservative management. Most times it is the first line of medical management that is usually started after when conservative management fails. So the side effects of tamoxifen includes it increases the risk of endometrial carcinoma. so one should be careful when using tamoxifen. Then bromocriptine is a dopamine agonist that depresses prolactin secretion, and it's been said to be effective in most patients. So the side effects are maybe people could experience dizziness, headaches, and vomiting. So these are basically the options for medical management. Then surgery includes excision biopsy. Now, if there's a definite localized mass in the patient, it should be excised for removal and for biopsy. Sclerosing adenosis. It commonly affects women in their mid-30s to menopause. It presents as a small mobile mass. Okay, it could present as a small mobile mass, an area of breast pain, or it could just be seen on mammography as an abnormality, mammographic abnormality. So there could be no mass, there could be no pain, but it is just seen on mammography as an abnormality suggestive of sclerosing adenosis. On palpation, the patient may experience trigger point pain on pressing the affected area. Microscopically, it is characterized by proliferation of acini and their ducts in a fibrous tumor. So when you look at it under the microscope, you see the abnormal proliferation of the acini, which is the glandular portion of the breast, and their ducts surrounded by fibrous tumor. The proliferation can cause impingement on nerve endings, and that's what results in this trigger point pain. The lesion may calcify and then mimic a carcinoma. Treatment is excision biopsy. Now, duct ectasia. Duct ectasia is dilatation of the lactiferous duct close to the nipple. You know, the lactiferous duct are the part of the duct that drain directly on the nipple. So the pathology behind duct ectasia: with fibrosis and aging, there is obliteration of the periacinal and periductal lymphatics, which are responsible for the absorption of secretions of the acini. Now, because of the fibrosis and then eventual obliteration of these lymphatics, the secretions of the acini are not being absorbed, and even the lymphatics that are present that may be able to reabsorb, they are only able to reabsorb the fluid part of the secretions. So meaning the larger molecules are still present, and then they accumulate in the duct and becomes progressively thicker over time and semi-solid. This accumulation distends the duct, and with distension of the ducts, the walls of the ducts become thinned out, and then they rupture with leakage of the lipid, as the content now, which is lipid secretions, into the surrounding tissue, and this results in periductal mastitis. That inflammation of the part of the breast around the duct, because the duct has opened up and the content has leaked into the breast tissue around it, and it results in it's called periductal mastitis. So you can see this diagram here. This is the normal duct, and then this is dilated and clogged duct. Now with increased dilatation, this wall becomes thinned out and then eventually ruptures, and then its content is released into the surrounding tissue, and that leads to periductal mastitis. So clinical features is common among women aged 40 to 50 years. It's commoner amongst elderly women, because as we said, with aging there is fibrosis of the periacinal and periductal lymphatics with subsequent obliteration. So it's commoner amongst older women. It may present as recurrent pain in the subareolar region. So there will be pain in the subareolar region. Could present as nipple discharge. Remember we said that anything that affects the ducts would lead to nipple discharge. Now the nipple discharge usually, it could be copious, and then in color it could be yellowish, it could be greenish, it could be brown, it could be black, but it is usually not bloody. This is to differentiate it from duct papilloma, in which you usually find bloody nipple discharge. There may be nipple retraction from fibrosis of the connective tissue. It may lead to nipple retraction. And then there may also be a mass under the subareolar region. Sometimes there could be no mass, it could just be pain, but there could be a mass. And then a mammillary fistula may result from recurrent subareolar abscess. Remember that we said when the ducts are dilated, they rupture and then its contents are released into the subareolar region. When there is superimposed bacterial infection, it leads to an abscess. Now, when there is recurrent subareolar abscess, a fistula may be formed. Now, a fistula is formed connecting the duct epithelium, that's the ruptured duct epithelium, to that of the skin, resulting in a mammillary fistula. On examination, there may be a tender induration or a frank lump in the areola, which may have some or all the features of adenocarcinoma, including nipple retraction, skin attachment, and then axillary lymph node enlargement because of the inflammation. With inflammation, there will usually be lymph node enlargement. Investigations usually, if there is nipple discharge, galactography can be done. For treatment, excision biopsy is done, and then when there is a mammillary fistula, the major duct with the fistula is excised en bloc, or the fistula is laid open to heal by granulation. So either ways, either the major duct with the fistula is removed en bloc, or the fistula is opened up and drained and allowed to heal by granulation. So here's a diagram showing a mammillary fistula. This portion you see outside is the outer part of the fistula. The inner portion is connected to the affected duct inside the breast. Breast cysts. Now, cysts in the breast develop in the lobular unit of the breast, which is the terminal portion of the breast. Pathogenesis is not well understood, and it is thought to be influenced by ovarian hormones. Now, breast cysts generally could be pathologic or physiologic. So, when it's pathologic, it results from ductal blockage by fibrosis or epitheliosis, which occurs in benign mammary dysplasia, just as we described earlier. In benign mammary dysplasia, there is fibrosis and epitheliosis that eventually leads to ductal blockage. Now, apart from this fibrosis and epitheliosis that occurs in benign mammary dysplasia, it can also result from an intraductal papilloma. So there is a swelling, a tumor in the ducts that actually occludes and blocks the ducts. Now, with ductal blockage, there is subsequent dilatation and destruction of the lobules and terminal ducts. Clinical features. It occurs in women aged 35 years and above. It presents with a painless lump of short duration. Some, however, have pain, and then most occur in the upper outer quadrants. They may appear suddenly in the mid-menstrual cycle and disappear after menstruation. Now, this is the physiologic breast cyst that may occur. On examination, they are soft, fluctuant of varying sizes with well circumscribed edges, and they are not usually attached to skin or underlying muscles. So they have benign features. Treatment is excision biopsy. So you remove the cyst and send for biopsy. So here's a diagram showing a breast cyst. Now, this is the cyst in the terminal portion of the breast that's affecting the lobular unit, and it occurs following fibrosis or epitheliosis of the ducts that drains the lobules of the breast, or it could be an intraductal papilloma present within the ducts of the breast. So the second broad group we're talking about now is lactational mastitis. The commonest inflammatory disease of the breast is bacterial infection, usually associated with lactation. It often arises as a result of cracks on the nipple due to the trauma of infant suckling. The common organism is Staphylococcus aureus. Rarer bacterial and fungal infections of the breast includes tuberculosis, infected parasitic cysts, recurrent subareolar abscess, actinomyces. Now, um, recurrent subareolar abscess obviously is a cause of non-lactational mastitis, because remember that it occurs following duct ectasia. With rupture of the ducts, there is periductal mastitis, and there may be eventually resulting in subareolar abscess. So this is a cause of non-lactational mastitis. So you can broadly say we have lactational mastitis and non-lactational mastitis. So you have the mastitis that occurs following lactation, when cracks on the nipple occur due to trauma of an infant suckling, or it could just be non-lactational mastitis. Now, treatment is with antibiotics, but when there is an abscess formation following this mastitis, it should be drained and not treated with antibiotics. Any abscess collection should be drained. Now, we talk about chronic breast abscess. Now, this usually occurs when an acute breast abscess was not properly treated. That's when it was treated with antibiotics, because every abscess should be opened and drained. So when an abscess is not drained and is treated with antibiotics, it does not resolve completely and presents as an antibioma. An antibioma is just a mass of is a hard swelling that contains sterile pus, and it is caused by long-term use of antibiotics to treat an abscess that should have been opened and drained. And its chronic breast abscess presents with features of carcinoma, such as nipple retraction. Okay, as you can see in this image now, nipple retraction, pudgy or orange appearance, skin dimpling. So it may present with such malignant features. So a chronic breast abscess is a very close differential to malignant breast disease. The mass may be tender and they may occasionally be pyrexia. So these features may help you differentiate it from malignant breast disease. And when you do a fine needle aspiration cytology to yield pus, treatment is usually by drainage and then biopsy of the mass. Traumatic fat necrosis. It occurs following trauma, including repeated minor trauma to the fatty tissues of the breast. However, a history of trauma is unobtainable in most patients because they usually don't remember when their breast was hit. So it could be maybe a woman just brushes her breast against a door or a cupboard, or it could be from vigorous movements of the breast. So they may usually not remember, okay, did somebody directly hit my breast or something. So following trauma, fat is liquefied and saponified by blood and tissue lipases. Saponification causes foreign body inflammation with macrophages and formation of tissue macrophages later. It presents as a hard, irregular mass, which may be attached to the skin, but usually not attached to underlying muscles. The surface is irregular. Nipple is not retracted, and axillary lymph nodes are usually not enlarged. Thus, it has features that are indistinguishable from early carcinoma. So, traumatic fat necrosis is a close differential of breast carcinoma, of early breast carcinoma. Treatment is excision biopsy. Galactocele is a milk-containing cyst and develops during lactation as a result of blockage and subsequent dilatation of a lactiferous duct. So when a lactiferous duct is blocked and then subsequently dilated, it results in a galactocele, usually milk-containing. It usually is sited under or near the areola, but may be in any part of the breast. It is usually painless or variable size. It is smooth surfaced, soft and fluctuant with benign features, meaning that it has no features of nipple retraction, skin dimpling, pudgy or orange appearance and all. So it usually has it appears benign. It usually disappears in a few days with massage, and the baby should continue to feed on the other breast in the meantime. But if the mass persists, excision biopsy should be done. So Tietz syndrome, it's not a breast disorder. is just okay. I chose to talk about it under these breast disorders because it's a close differential of breast disorders, both benign, um majorly benign breast disorders. So this is a condition in which there is inflammation of the costochondral junction and adjacent costal cartilage, usually the second. Since the costal cartilage is related to and is covered by breast tissue, the pain can be mistaken for breast pain. So the pain can be mistaken for breast pain. It's a very close differential of causes of breast pain. Okay, it's one of the differentials for causes of breast pain. Typically, there is tenderness on palpation, and there is no clinical, radiological, or pathological abnormalities of the breast. So when you've taken a history, there is nothing to suggest any breast pathology. When you examine, there is nothing in the breast. Even when you do a radiological investigations, there's nothing. You suspect tear syndrome. Treatment is by reassurance, and then NSAIDs may be given. Steroids and local anesthesia may be used if pain persists. In conclusion, benign breast disorders are varied and commonly affect women in their lifetime. Most benign conditions occur in the reproductive age group because of the hormonal changes that occurs monthly. These reproductive hormones play a role in the pathogenesis of certain benign breast conditions, as we saw during our discussion. Can we remember any? Benign mammary dysplasia is one of them. Now, benign breast lesions are commonly painful as against malignant lesions that are painless. However, certain benign breast conditions mimic carcinoma and are thus close differentials of a malignant breast disease. A careful history and physical examination is important in making a diagnosis of a benign breast lesion. References: Baydo Principles and Practice of Surgery. And thank you very much. And I hope you learned a whole lot from this tutorial session. So this marks the end of our discussion on benign breast disease. We'll begin our discussion on malignant breast disease in our next tutorial video. Thank you for listening.